Today we'll talk about naltrexone and naloxone and their pharmaceutical properties. We will also talk about the overdose management and the FDA approval for naloxone. Objective for today's discussion, we're going to talk about the opioid overdose management from FDA, DEA, and more references. What is naloxone and naltrexone, then the pharmacological properties, effects in the absence of opioid agonists, and similarly then effect in the presence of opioid agonists, and then the effect in the dependent patients. And then we'll also talk about absorption, distribution, metabolism, and elimination. All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today is the 16th lecture in the pain management or DEA requirements for the opioid use disorders and management in the pain management. This is also the second last lecture. Today we'll talk about naltrexone and naloxone and their pharmaceutical properties. We will also talk about the overdose management and the FDA approval for naloxone. Next week will be the last lecture in this series, and that is when we'll talk about the therapeutics and the indications of these drugs. So with this, thank you very much for joining, and I'm going to share my screen and we will go from there. So first of all, this is the drbeen.com. Here, either in the library, you can see here DEA requirement for opioid use disorder, or you can do this drop down and go here to DEA requirements, or the same set of lectures is also present within the pain management. The reason I collected the same lectures under two separate headers was that I was seeing people asking me for the same lectures either under pain or DEA, and I thought I would just set them in those categories. Now, after this, and there are about 10.5 CME hours. Today would be probably another half or 1 hour, and then next week will be another. So we might end up with 12 hours, out of which 8 hours are required. Okay, so quick references. This is the FDA approval. So FDA approves first over-the-counter naloxone nasal spray or So this is then the Drug Enforcement Agency, United States Drug Enforcement Administration, and they talk about naloxone as well. Then some more references for naloxone and naltrexone. All of those references are actually listed at the end of the presentation as well. So just wanted to give you a quick look, and now let's start. So naloxone and naltrexone, one interesting thing since we last talked is that I have been nominated as a visiting faculty for King Edward Medical University, plus I have been made advisory board member for the Annals of KEMU. So that's a couple of good honors that I received. So disclosures, I have no disclosures. Objective for today's discussion, really, if you leave the first one aside, we're going to talk about what is naloxone and naltrexone, then the pharmacological properties, effects in the absence of opioid agonists. So that means if somebody who does not use opioids and you give them naloxone, what will happen? And similarly then, effect in the presence of opioid use. So that means if somebody is a patient and who has been prescribed opioids, and then if you give them naloxone or naltrexone, what happens to them? And then the most important thing here, effect in the dependent patients who have been using opioids for a longer period of time. And then you give them naloxone or naltrexone, what happens? What kind of effect can come in? And then we'll also talk about absorption, distribution, metabolism, and elimination. If you can see, the next part would automatically be the therapeutics. We'll do that next week. And now if you look at the very first bullet point, that is the opioid overdose management from FDA, DEA, and more references. I wanted to make sure that we put that front and center, because at the end of the day, that is one core outcome of this whole course. So I'm going to actually start from there. So This is now references FDA. FDA says that drug overdose persists as a major public health issue in the US, with more than 101,750 reported fatal overdoses occurring in the 12 months period ending in October 2022, primarily driven by synthetic opioids like illicit fentanyl. So that's pretty sad that more than 100,000 people die of primarily drugs like fentanyl. So the over-the-counter naloxone for opioid overdose. This is such an important step that is taken that naloxone has been made. It was actually approved in 2015, but it was for with prescription only. And now it has been made since 2023, March 29. It has been made over the counter because one, the drug manufacturers have been able to show the safety and efficacy of this drug. Secondly, the efficacy in protecting, saving lives is such an important milestone that they were able to show with safety of the drug that FDA went ahead and made it over the counter. That is such an amazing thing that has happened. And it is actually interesting. If you can indulge me for a second, actually, I closed it. If you go to the Drug Enforcement Agency's link that I had, um, you will see that they have a 1 minute video over there where there is a teenager or a little more than the teenager youngster, and she's preparing to go to a party and she's picking up everything. And then they stop the video and they say, the one very important thing to take with you is the naloxone nasal spray. So that is how they have been promoting it, to say, take it and keep it with you. So OTC naloxone for opioid overdose. Today, the US Food and Drug Administration approved Narcan 4 milligram naloxone hydrochloride nasal spray for over-the-counter non-prescription use, the first naloxone product approved for use without a prescription. Naloxone is a medication that rapidly reverses the effects of opioid overdose and is the standard treatment for opioid overdose. It's a standard treatment, plus it is rapid. It starts working within minutes. And so somebody who is in overdose, somebody who has respiratory depression, somebody whose respiration may actually be almost stopped as well, this drug can help. Today's action paves the way for the life-saving medication to reverse an opioid overdose to be sold directly to consumer in places like drugstores, convenience stores, grocery stores, and gas stations, as well as online. The approval of OTC Narcan nasal spray will require a change in the labeling for the currently approved 4 milligram generic naloxone nasal spray product that rely on Narcan as their reference list drug product. So the use of Narcan nasal spray in individuals who are opioid dependent may result in severe opioid withdrawal. So this is very important. Whenever somebody who is opioid dependent, and we have done in detail what we mean by opioid dependent, how does that dependence develop, and what happens with the withdrawal, those lectures have already been done. Usually, in the previous lectures, we talked about the opioid withdrawal when somebody stops opioids. Here, an important mechanism to keep in mind is that somebody who is on opioids, either illicit or dependent will mean that they actually are prescribed opioid under medical supervision, and they have, with the continuous use, become dependent. They will not be called, this will not be a disorder, this is dependence. So either there is dependence or there is illicit use and use disorder. When these drugs, antagonists, are given, for example, let's say naloxone, what they do is these drugs will go and remove the opioids that are bound to the receptors. And that is as similar to as you stop opioids abruptly. So withdrawal can occur. So that is the only important thing to know for a practitioner, that it is possible that the withdrawal symptoms may appear because giving these drugs is equal to abruptly stopping opioids. However, please remember that when somebody is in respiratory depression, somebody is going to die possibly, these drugs are not asked to not be given, that the patient would have withdrawal issues. They are safe and they would protect the person's life. Okay, so the use of Narcan nasal spray in individuals who are opioid dependent may result in severe opioid withdrawal characterized by body aches, diarrhea, increased heart rate, fever, runny nose, sneezing, goosebumps, sweating, yawning, nausea, vomiting, nervousness, restlessness, irritability, shivering or trembling, abdominal cramps, weakness, and increased blood pressure. And I am so happy to put this list in front of you because we have talked about every single mechanism behind these symptoms. So now this is the Drug Enforcement Agency and their message about opioid overdose. So save lives with naloxone. What is naloxone? Naloxone is a medicine that rapidly reverses an opioid overdose. It is an antagonist. We'll talk more about that a little later. This means that it attaches to opioid receptors and reverses and blocks the effect of other opioids. It kind of removes them from the receptors, the opioids. Naloxone can quickly restore normal breathing to a person if their breathing has slowed or stopped because of an opioid overdose. How is naloxone given? Naloxone should be given to any person who shows signs of an opioid overdose or when an overdose is suspected. Naloxone can be given as a spray or it can be injected into the muscle, under the skin, or in the veins. Now, there is an important concept over here, and that is if you see a person in respiratory depression and you're not sure if it is opioid or not, you can still, and if you have, you should still administer the naloxone nasal spray, because if they are in the opioid withdrawal or overdose, their life will be saved. And if they are not in the overdose, if it is not opioid, administering naloxone is safe in those who do not have opioid in their body. So the consideration in health. So this is an important part which I'm going to discuss. Let me put that in front of you first. When you give naloxone nasal spray for helping with the opioid overdose, where somebody is in respiratory depression or the respiration is stopped, the half-life of naloxone is short. It is about an hour, but the clinical effective window of naloxone is actually very short. It's in minutes. However, many of the opioid agonists, for example, let's use fentanyl for our example. Fentanyl will be an opioid agonist. It is an opioid. Agonists mean it will bind to the opioid receptors and stimulate them. Fentanyl has a half-life of 3 to 7 hours. So imagine that somebody is in respiratory depression because they have taken fentanyl. You have no idea when did they take fentanyl. But imagine that they just took fentanyl 10 minutes before you found them. That means their fentanyl is going to be effective in their body from 3 to 7 hours. You found them, they're in respiratory depression. You gave them the nasal spray in each nostril, and they felt better. They started breathing within a minute or so. And as you would see a little later, that you can continue to give them nasal spray every 2-3 minutes. So let's say you've done the first one, they started breathing, you're feeling better. The important thing to keep in mind is that that person is not out of danger yet. The reason for that is that the naloxone and its clinical efficacy will very rapidly wane. But fentanyl would still be present in this person's body and effective for up to 3 to 7 hours. So as soon as naloxone is removed, fentanyl will bind to the receptors again, causing the overdose symptoms once more. So that means you have to continue to support with the nasal spray. Every 3-4 minutes, you are administering the spray until the emergency respondents, they come in and they take over the patient. So that is what I'm going to quickly present to you over here. In health, therefore, morphine displays an elimination half-life of around 115 minutes. What I'm presenting to you over here is the opioid agonists, morphine, fentanyl, their half-life is long. So here is morphine, 150 minutes half-life. If you see the second paragraph over here, fentanyl is hepatically metabolized via the CYP450 enzyme system. The drug has a half-life of 3 to 7 hours, right? So the takeaway from these two paragraphs is that these opioid agonists can have a half-life, can have their clinically effective duration longer than naloxone. So here I made this little chart. Imagine that somebody has taken fentanyl and imagine that the duration is 3 hours. So if you see here, hour 0, hour 1, 2, 3. So here they took fentanyl and they took it so much that they are now in overdose and they have a respiratory problem, depression of respiration, and maybe even stop respiration. You found them, you administered naltrexone, or sorry, not naltrexone, naloxone nasal spray. That has a half-life of 1 hour and the clinically effective time is even shorter. Then this time when the naloxone is given and it has done its function and it has helped reverse the effect of fentanyl and the patient has started breathing, then the naloxone's effect went away. Now the patient is in a danger area, which is the re-narcotization is possible. That is that the fentanyl that is present in the system, which was displaced by naloxone, can now have a chance to rebind with the opioid receptors and re-cause the depression. So that will be called re-narcotization. And if you are there or someone, whoever is there helping the patient, they would continue to administer naloxone. So here in the home setting, 0.5 milligram of naloxone can be administered via auto injector every 2 to 3 minutes while awaiting emergency medical assistance. This is a very important point to keep in mind. Then this is another site. This is Medical News Today, Narcan overdose. So can this naloxone itself be overdosed? Should you be careful that I might end up causing overdose of the antagonist? So let's see this. There is no maximum recommended dose for Narcan, and you can't hurt someone by giving them more doses of naloxone than they actually need. In fact, if someone has overdosed or possibly overdosed on opioids, you should give them naloxone every 2 to 3 minutes until they begin breathing normally again. After calling 911, you should continue to administer naloxone as needed until emergency medical staff arrives. And you must be seeing that I'm trying to switch the word from Narcan to naloxone because I'm doing a CME lecture, and in here, brand names are not usually used, although there are many drugs, naloxone, that can be under the name of Narcan. So naloxone is the drug we're talking about. So I hope that this consideration is clear. Now, with the overdose and the standard over-the-counter management drug and the management process. Now I'm going to go to the pharmaceuticals of the naloxone and naltrexone. So first of all, please keep in mind in here in this diagram, this gray area, these gray blobs, that is a opioid receptor. Just to refresh, we have the mu receptors, delta receptors, and kappa receptors, or MOR, DOR, and KORs. Mu are the most abundant and mu are the most clinically targeted as well. If you see on the left side, I have made this diagram where the blue guy is the naloxone. And what it is doing is it is removing, let's say this is morphine or fentanyl, from the opioid receptor. And as you can see that it is kind of removing it with force. The reason for that, if from today's lecture, you can just take this much, that naloxone has a very high affinity for opioid receptors compared to naltrexone. Then my job is done. Why? Because naltrexone is not used for emergency management of opioid overdose, while naloxone is used. And the reason for this is, one, naloxone is rapidly acting. And why is naloxone rapidly acting? Because it has a greater affinity for the opioid receptors. So even when the opioids are bound to the receptors, imagine you are an opioid for a second, no offense, and you're sitting in a chair. Even if an opioid is sitting on the receptor, it is bound to the receptor, the naloxone can come and because it has a greater affinity for the receptor, it will displace the opioids and take that position, take that receptor. Now, this drug, naloxone, is actually a modified opioid, we'll discuss a little later, and when it takes that receptor, it does not stimulate it. So it really stops the action of opioid agonist on the receptors. On the other hand, if you look at the right side, that is also an opioid receptor. And you see there is another reddish color opioid sitting there, morphine or fentanyl. But if you see here, this green one is naltrexone, which is kind of struggling to remove it, to remove the morphine or fentanyl or opioid agonist. The reason is that naltrexone has lesser affinity compared to naloxone for the opioid receptors. So it has to take its time, it has to develop its concentration because it is not as powerful, which is the wrong pharmacological term. The right term is affinity. It doesn't have as much affinity as naloxone. Because of that, it doesn't have rapid action. On the other hand, naltrexone has a very interesting mechanism or advantage, and that is when taken orally, naltrexone can become systemically available. The liver doesn't break it down all. On the other hand, naloxone, when taken orally, is almost entirely metabolized by the liver and destroyed. Because of that, naloxone is taken parenterally, that is other than the oral route. That may be nasal spray, or that may be intramuscular, or that may be intravenous, or that may be subcutaneous, but not through the oral route because liver would destroy it. This is why naloxone comes in the parenteral methods, and naltrexone can be oral. So these are the couple of things that I wanted to keep in mind. And I was so proud of these diagrams that I actually signed them. So that's one. So now let's very quickly look at some of these properties. Naloxone, it is lipid soluble. And why is that important? It is lipid soluble because of its lipid solubility. It can cross the blood-brain barrier and go and displace the opioids that are active in the brain as well during the overdose, especially. So I want to then leave another thought in your mind as we are discussing this, and that is there may be patients who are on opioid because you prescribed opioid. They are taking opioids under medical supervision, but they have opioid side effects that you want to counter. Most importantly, peripheral side effect, and that is GIT, gastrointestinal system's movement issue, and constipation. So imagine that there is a patient who's taking opioid and has these side effects, but opioid is needed. If you give them naloxone or naltrexone, these drugs would just remove opioid from the whole body, including the brain and the spinal cord. So they would cancel the effect of opioids. We want the effect of opioid in this patient because they need this intervention, but we do not want the peripheral side effects. So in such cases, we have special molecules, for example, methyl naltrexone, methyl, it is methylated, special molecules that cannot cross the blood-brain barrier, which when given to the patient would stay in the peripheral tissue and take care of the GIT and constipation side effects while not going to the central system and not remove the opioids over there, so patient can continue to take opioid for their basic advantages and the side effects can be taken care of. This is why it is important to keep in mind that naloxone and naltrexone are lipid soluble. That means they will go to brain and they will displace the opioids over there. Then, so these are lipid soluble, non-selective. Non-selective means that these molecules will act on mu receptors, delta receptors, and kappa receptors, but their affinity for these receptors is variable. They are really, really attracted towards mu and maybe lesser towards delta or kappa. And these are called antagonists. And it is such an interesting thing. These both the medicines are actually made by a small change in oxymorphone, which is derived from morphine. So they are actually themselves like opioids. They are derivatives of opioids, but they have been modified in a way that they have lost their activity on the opioid receptor. So they actually bind to the opioid receptor because they look like an opioid molecule, but when they bind on the receptor, they have modifications in them that make them functionless, opioid functionless. And now when they sit on the receptor, they're not doing any function. We will call them to be antagonists. They are now doing the opposite. They are removing the action of that receptor on which they are sitting. Very interesting. So naloxone is known as N-allyl normoxymorphone, or another name as well. It is a synthetic derivative of oxymorphone. Oxymorphone is a derivative of morphine. It is rapid-acting naloxone, apparently devoid of agonistic activity for all opioid receptors. So I'm going to talk about that in a second, but it is important to understand that antagonists, that is the one that counter the opioid action, because antagonists are made from taking an opioid molecule and modifying it, there are some antagonists that still have some level of agonistic activity, that still have some stimulation for the receptor. But please remember, naloxone and naltrexone have, apparently, they have zero agonistic activity. They're pure antagonist, which we would love to have. So apparently, naloxone is devoid of agonistic activity for all opioid receptors, but with varying affinities. Now, naltrexone, similar thing, it's lipid soluble as well, so goes to brain. It is also non-selective competitive antagonist of the opioid receptors. Here is its chemical name. It is also derived from the same oxymorphone with another kind of a modification. It is also, it doesn't have agonistic activity. It is orally bioavailable because the liver does not destroy it as it does, as the liver destroys naloxone. And it is slow acting and it has a longer duration of action. Because of that, although they are very similar molecules, their therapeutic use is different. Some opioid antagonists may be competitive antagonists at more, but agonistic at core. So this is what I mean, that other antagonists may still have some activity. For example, as we go to the next one, here, let's see. The very first diagram, this little, these circling little things are the G proteins, and the morphine is attached here. And if you see down here, these electrical shocks, that is the activity within the cell. So this is the morphine, fentanyl, or other opioid agonists, and they are activating the receptor, opioid receptor. If you see in the center, this is nalorphine or levonorphin, which are also antagonists, but they are not non-selective antagonist. They are antagonist on the mu receptor, which is important, but they're not antagonist on the kappa receptor. They are actually agonist of the kappa receptor. They behave as if they are stimulating those receptors. So they are mixed. They are antagonist and agonist. On the other hand, naloxone and naltrexone on this extreme right are antagonist for MOR, DOR, and KOR all. This is why these two are very important. Then one more quick diagram. I said a few minutes ago that the receptor affinities are different. What does that mean? Imagine that this is any one of the antagonist or agonist. They all behave with the same way. And the gray one here is the receptor. Let's say this is the opioid receptor. And let's say these molecules on the left is, let's say this is the naltrexone or naloxone. Let's actually start with naloxone. Naloxone has a very high affinity for the receptor. It binds tightly with them. It can actually displace any opioid sitting already over there and go and bind there. It has high affinity. So as you can see, it is really hugging the receptor and holding it tight. In the middle, that can be naltrexone. So naltrexone has lesser affinity compared to naloxone. So it would not force and remove things. It may have lesser affinity. And then on the extreme right, maybe another drug which has very less affinity. So the receptor affinities can be different, and based on that, the drug's behavior can change. Now, a quick note between the differences between naloxone and naltrexone. So the middle column is naloxone, and the right one is naltrexone. So naloxone is rapid reversal of opioid dose. That is where it is used. Overdose of opioid, rapid reversal, even prevention. That is if you're suspecting that somebody is about to take morphine or fentanyl and you want to prevent an overdose, you can give them naloxone. So it is for prevention and reversal of the opioid overdose. Naltrexone, on the other hand, because it doesn't work that rapidly and it has a longer duration of action, it is used for alcohol and opioid use disorders. And I'm not talking about low-dose naltrexone. That is an entirely different mechanism, and we have some part of that mechanism is unknown, some is known. I've done a separate discussion. I'm talking about naltrexone full dose, for example, 50 milligram per day. Now, naloxone has a shorter half-life, as I said before, about an hour, but the clinical effective time is even shorter. Naltrexone has a half-life of about 3 hours. Then the duration of action is about 24 hours. And naltrexone is converted into another metabolite within our body called, I believe it is called the 6-naltrexone, which has half-life of 13 hours. And that is also weak antagonist. Then we already talked about it. Naloxone is a high affinity molecule for, or it has high affinity for opioid receptors. Naltrexone has low affinity or lesser than naloxone affinity. Similarly, naltrexone is orally available. Naloxone is not because liver metabolizes it. So Randy says, is naloxone less effective against nitazenes because of the drug's greater affinity or some other reason? So if the drug has a greater affinity, for example, when we are in an overdose, the naltrexone doesn't have sufficient affinity to be able to remove enough opioids and agonists to help the patient come out of it. So it is weaker. Instead, naloxone is the one that would be something to compare here. Now, exactly the affinity distance or difference between nitazenes and these, I'm not aware of that. I will do some research. And Randy says, hope Dr. Bean covers these new synthetics. I can, if we would like to continue on those, I can have those discussions too. Thank you, Michelle. Okay, so that is the difference between naloxone and naltrexone. Now, some pharmacological properties. Opioid antagonists produce a few effects in the absence of exogenous opioids. This is a very, very interesting topic. Opioid antagonist, meaning they counter the opioids, when given to a person who doesn't have opioids in them. So imagine you and me right now. We hopefully none of us have opioid in our system, exogenous opioid that is from outside. And you give us, let's say, naloxone or naltrexone. The question is, what will this drug do now? So fortunately, the endogenous opioids, the opioids that we produce inside of our body, and the physiological activity of opioid receptors isn't as profound that when given the antagonist, we observe something big happening. Because of that, it is said that opioid antagonist, when given in the absence of exogenous opioid, in the absence of outside opioid, the effect can be from nothing to slight hyperalgesia type effects. But I'm going to talk a little more in depth. Hyperalgesia is more feeling of pain. And I think that is understandable that we all have internal pain gating and pain management mechanisms. One important part of that is internal or endogenous opioids or opiates. They help manage the pain. So imagine we all are producing our own internal opiates, which are helping with our own internal pain management pathways, and you give antagonist, then it is possible that our feeling of pain can increase. Especially, for example, those patients that are given placebos as a pain management medicines or interventions, or patients who receive acupuncture for pain management, if you give them opioid antagonists like naltrexone, they might actually start feeling pain. So it is possible that hyperalgesia or increased sensitivity to pain can occur. So opioid antagonists produce a few effects in the absence of exogenous opioids under ordinary circumstances. For example, naloxone is deemed safe to administer to someone suspected of the opioid overdose, even if they may not actually be suffering from opioid overdose. Under certain conditions, for example, shock, when endogenous opioids are active, so a person under shock, when the blood pressure is all falling and there is a crisis going on, internal opioids are active. And when you give an antagonist, that antagonist is going to counter the internal endogenous opioids. So just administration of the opioid antagonist can have positive hemodynamic effect. It can actually counter the endogenous opioids and help. On the other hand, there is an effect on hormones that I want to discuss that as well. So keep in mind yet that we're going to discuss that. Subcutaneous naloxone up to 12 milligram produces no discernible effects in humans. 24 milligram causes only slight drowsiness. Naltrexone has higher oral efficiency and a longer duration of action. Opiate antagonism in human can range from no effect to mild hyperalgesia. Antagonists like naloxone may attenuate the effect of placebo medications and acupunctures. Now, effect on hormones. This is really, really important. Endogenous opiates that we produce all the time, and as I said, they do not have that profound physiological function, but they are still helping manage pain, and they are also helping manage pituitary action or pituitary action. And what is that management they participate in? They cause tonic inhibition of pituitary release. So they kind of reduce the hormonal controls from pituitary to the remaining system. That is the opioid, internal endogenous opiates. Now, if you give the antagonist, for example, naltrexone, what is that going to do? It is going to go and counter internal opiates and counter the effect of those on pituitary, which will cause the tonic inhibition of pituitary to become disinhibited. And the hormonal release will become different. So 3 important changes. Number 1, GnRH, releasing gonadotropin releasing hormone, CRH, corticotropin releasing hormone, and prolactin. We'll go to prolactin in a second. So when the GnRH and CRH are increased because of giving naltrexone or opioid antagonists, the result is that the person receiving these drugs will make more luteinizing hormone, more follicular stimulating hormone in women, more adrenocorticotropic hormone, and even more steroid production. This is very important to note. And this is I found very few literature items that touched on these things. Michelle says that Mubin takes a topic and makes it so fascinating. We research, I wouldn't think to look up. That's my job, right? To bring these topics, to go and curate and find that information and put that in one place and cook this beautiful meal for you. So hormonal regulatory mechanism. I was blown away when I read this, and it is actually understandable. Endogenous opioids or opiates usually keep an inhibition, some inhibition of the pituitary release. So they're not total inhibitory control, they are participant in it. And when you block them by giving antagonists, then pituitary becomes released, a little more released. So then the patient has, or the person has, more luteinizing hormone, more follicle stimulating hormone, more adrenocorticotropic hormone, more steroids, and more prolactin. More prolactin could result in expression of milk in women. So if you see here, naloxone stimulates prolactin in women. So that is one. We are talking about giving antagonist in individuals who do not have exogenous opioids, people without opioids, endogenous opioids only. So that's one set of effects. Second set, food intake. Interestingly, naltrexone, when given to obese people or lean people, it reduces their hunger. So they have, of course, done studies to see, can this be used for a weight loss drug? And as much as they see that there is a hunger reduction, it isn't sufficient to actually cause weight loss. But there is hunger reduction. Then effect of long-term administration. So these are short-term. Long-term administration of opioid antagonists. Think about it with me for a second. When we were doing the opioid agonist or opioid actions, we were saying that our cells will downregulate the receptors. So now let's go to the opposite direction. Imagine I am a cell, the whole thing, I am a cell, and I have some opioid receptor on my surface. You administer antagonist, for example, naltrexone or naloxone. They come and they occupy the opioid receptor on my surface. And now me being a cell, I'm getting less opioid stimulation because the receptors are covered with these blockers who are doing nothing but just sitting there and not letting even endogenous opioids to act. What will this cell do? I would start making more opioid receptors. I would upregulate opioid receptors and express them out on my surface, thinking maybe there is less opioid in the system. I need to kind of catch some opioids. So I should make more receptors and put them out for a chance of grabbing hold of some opioid that is passing near me. So if you continue to give me antagonists, which block my opioid receptors, I will continue to make more and more receptors and put them on my surface. I would upregulate, I would increase the density of the receptors. Now, if by any chance you give me an opioid, think what will happen. I was primed with the upregulation to respond to opioids, to catch as many opioids as I can. Guess what would happen? I have such a high density of receptors. You give me opioids, all those receptors are going to get bound to the opioid and respond aggressively. What would happen is I would have an exaggerated response to opioid for some time. Then my cell, I was a cell here. Then I would once again notice that, hey, I'm responding too much to opioid. Then I would start down regulating the receptors and kind of adjusting again. But till the time I down regulate, I will be giving an exaggerated response to the opioid dose, which later on will not produce such a response. So opioid antagonists, for example, naltrexone is very commonly used nowadays for some other uh, conditions as well. I don't want to talk about them here because it's a CME lecture and these are off-label usage, so I'm going to leave that. But that usage of naltrexone antagonist in a person without taking opioid would actually prime their system to respond more if they ever receive opioid. So just keep that in mind. So this was, so Crystal says, when the cell increases its number of receptors, do they ever return to normal number of receptors? Yes. Cells upregulate and downregulate the receptors all the time. They continue to adjust. They have an internal system to understand how much stimulation should they get. And if they're getting less stimulation, they would try to upregulate the receptors. If they're getting too much stimulation, they would try to downregulate the receptors. And we actually had that discussion when we were doing the opioid receptors, that as soon as opioids are given, within a few minutes to hours, the body starts adjusting itself to adapt to the opioids. One adaptation mechanism is upregulation and downregulation of the receptors. So Susan says, will this result in lowering the dose needed for patient wanting to reduce dependency on opioids? So antagonist and the management of the patient's use disorder is a very different topic. Here, what I wanted to make sure that you are aware that if some patient is getting antagonists for other reasons, their opioid receptors are upregulated, the density is increased, and if you give them opioid, they would have an exaggerated response. That might surprise you that, hey, I gave this dose and this dose normally doesn't do in others what it just did to this patient. So don't become too surprised that patient may have been taking antagonists and may have been having an upregulated receptor density. This will become corrected a little later. This is a temporary effect. Okay, so part two, effect of opioid antagonist in people who have been using opioids. So we just did previously the effect in those who were not getting exogenous opioid. And we saw that there was an effect on hormones, there was effect on hunger, and then we saw that there was effect on the chronically using the drug and overexpression of the receptors. Now we're talking about those who had taken opioid or who have been taking opioid. If you give them antagonists, what would happen? So I want to prime you before we look at this content. Imagine I'm taking opioids. An opioid is bound to my receptors, opioid receptors. And my body is responding to that. I have adjusted to it. And we have done all that discussion in hours long discussion lectures before. If I abruptly stop taking opioids, what will happen? I might develop withdrawal, correct? You could trigger similar withdrawal just by giving antagonists, because the antagonist's job is to go and remove the opioid from the receptors, which is equal to not taking opioids. So keep this in mind and then look at this content. So effect in the presence of opioid agonists. Naloxone, 0.4 to 0.8 milligram intravenous or intramuscular, promptly reverses or prevent the effect of opioid agonist. So that is one. Of course, we discussed for overdose. Naloxone 0.5 milligram subcutaneous. The first line was IV or IM, intravenous or intramuscular. Now we're talking subcutaneous. 0.5 milligram subcutaneous can precipitate moderate to severe opioid withdrawal syndrome. So you'll be saying, why withdrawal syndrome? Because naloxone went into the system and removed all the opioid as if the patient had stopped taking opioid. That would trigger withdrawal syndrome. And I have already put this in front of you that naloxone lives for shorter time. And if the opioid present in the system is longer, half-life and it was given just before, then as soon as an naloxone would come in and displace it and the patient would start developing that syndrome, then the naloxone's own effect goes away, then the re-narcotization would occur. So naloxone 0.5 milligram subcutaneous can precipitate moderate to severe opioid withdrawal syndrome. This effect is similar to abrupt opioid withdrawal. However, it appears within 2 minutes of the drug and lasts for up to 2 hours. Up to 2 hours. It's not necessarily always 2 hours. It kind of stops before 2 hours because of the short duration of effect of naloxone. But starts within two minutes. And that starts within 2 minutes is what we use for overdose and for rescuing the patient from respiratory depression. Now, I want to add one more statement over here. I'll forget. The naloxone's effect on respiratory depression is known during overdose. However, its effect on the central nervous system depression isn't as clear. But still, respiratory depression is something that can kill the patient. So it is very important to use it to protect the person. The severity and duration. So I think this statement that I'm going to make, this is understandable as well. The severity of the withdrawal syndrome and the duration of withdrawal will depend upon how dependent is the patient on opioids, how much are the opioids in their system, correct? So the severity and duration of the withdrawal syndrome will depend upon the dose of antagonist and type of opioid dependence. Makes sense? Now, imagine we have a patient who is opioid dependent. That means that patient was given opioid, prescribed opioid by you for illegitimate medicinal purpose. It's a medically supervised opioid and the patient has developed dependence. Patients dependent on pentazocine, butorphanol, nalbuphine will have withdrawal syndrome when naloxone is administered. Now, managing peripheral side effect, I discussed this before. We are talking about the patients who have opioids being given. So this is what we discussed before as well, that there are patients where you are using opioid for them to manage whatever their condition may be, and they have this unwanted side effect in the peripheral system body, that is the GIT mobility is not correct and they are constipated. So in such cases, you give antagonist while you're giving agonist, while you're giving opioid, you give antagonist that would only stay within the peripheral system. And these are specially modified molecules that cannot cross blood-brain barrier, for example, methyl naltrexone. So here, methyl naltrexone subcutaneous 0.15 milligram per kilogram will produce reliable bowel movement without discernible central effects. So patients with early acute physical opioid dependence. This is a very interesting point. We're going to talk about the overshoot phenomena. And what is important in here is early acute physical dependence of opioid. It can develop within 6 hours. You gave me a dose of opioid now, and within 6 hours, I could develop an early acute dependence. And we did this discussion before that why within minutes our body started adjusting to opioids and start becoming adapted to it. So it's a very interesting situation where the patient with early acute physical opioid dependence after even a single dose of mu opioid receptor agonist, if you take such a patient and if you give them antagonist, they could develop overshoot phenomena. So I want to make sure that we we are on the same page here. Somebody received opioid agonist 6 hours ago. And we thought, well, that would not produce any dependence. So maybe I can use antagonist for whatever is the reason. Let's say there is a reason to use antagonist. Maybe they are developing some sort of overdose type behavior. But we may not know that they have actually developed early acute physical dependence with just one dose of agonist. And now giving antagonist would trigger overshoot phenomena. So what is that? So I want to read this whole paragraph. It is beautiful, and the reference is down here. Although not causing critical adverse effects in opioid naive or non-dependent patients, administration of the pure antagonist may be associated with the withdrawal syndrome in dependent patients, causing a range of withdrawal signs and symptoms from mild, unimportant clinical manifestations, including yawning, lacrimation, diaphoresis, rhinorrhea, piloerection, mydriasis, vomiting, diarrhea, myalgia, to severe withdrawal signs and symptoms, the most important of which is overshoot phenomena. The overshoot phenomena may result in hyperventilation, tachycardia, hypertension due to the release of catecholamines and can induce very severe and important complications such as myocardial ischemia and infarction, heart failure, and central nervous system injury. In overshoot, somebody who received an opioid agonist 6 hours ago, gave an antagonist after 6 hours or 4 hours or 5 hours, and all of a sudden they have a heart problem. What happened? They developed overshoot phenomena. Why? Because they released a lot of catecholamines. And we have done this discussion that why do they develop these catecholamines? Why do they have these enzymes super primed? And why are they now responding this way? I think it was third or fourth lecture in which we discussed it. So this is an interesting one. The rest of the paragraph is interesting too. I'm going to leave it. The reference is in there, plus this is here as well. Now, naltrexone is much more potent than naloxone. We did this discussion before as well. Naltrexone is much more potent than naloxone, and 100 milligram oral dose, 100 milligram naltrexone, given to patients addicted to opioids, produce concentrations in tissues sufficient to block the euphorogenic effects of 25 milligram IV dose of heroin for 48 hours. Naloxone is rapid. Naltrexone is bioavailable through oral route plus more potent. So much more potent that if somebody is given heroin, 25 milligram IV, then 100 milligram of naltrexone can protect from the effect of heroin for 48 hours. So this is the discussion.